let's begin by looking at the analytic biomarkers and trying to position them in what we do today. I'm sure all of you are aware of some of the classic issues that are brought up today when you're talking about the functional approach to health. And it's really the classic thing was the tree with the leaves, the trunk, and the roots. And the idea is, what are we really trying to do? The problem for conventional medical thinking is that it really is focusing on what we could consider as symptoms, not systems. Really just the symptoms, when you really should be looking at the systems. Secondly, most of the time you're looking at organs as opposed to the whole organism. The whole idea of a holistic look is not something which you see in most conventional medical thinking. And I'm using a broad brush here. There are many people in the medical profession who don't do it this way, but there's no doubt that it is an issue. So it is not really the disease that you have, therefore. It's not why you have the disease you have, not why you have the disease. And so really today we're not focused on the root causes. And you can see in this slide all of the different things that we are aware of that can lead to the various types of symptoms and signs of actual disease. By the way, for those of you who want to know, I can give you a PDF of this if you would like, so you'll be able to actually look at it in detail. And so therefore, we do know that the major causes of disease are toxins, allergens, stress, microbes, poor nutrition, the things we're very well aware of. And the ingredients for health are really to decrease to low amounts the amount of processed foods, to have balanced nutrients, a stable environment, and of course to get sufficient exercise and sleep. So everybody says, that's great, Dr. Gonshor, we all know that, can we leave now? Well, that is just a general statement. Let's really delve into what that means. Vojdani in 2015 came up with a very interesting slide which took information about autoimmune disease in the US in the mid-2015 period. And what we see is that one out of two, maybe even more, Americans are suffering from some kind of an immune disorder. That's in millions of people. So that's a vast number of people. And the question really becomes, why is that the case? Very interestingly, for example, with autism spectrum disorder, ASD, in the US, there has been an exponential increase since 1975, where it was 1 in 5,000 that was ASD. And by 2012, it was 1 in 88. And if you take a look at the CDC's estimate in 2020, which is really looking at figures from 2016, it's about 1 in 54. What is going on here? I mean, there is no question. One could say, well, in 1975, we weren't really seeing each person who might have had autism as being on the spectrum. I grant you that. But that in no way explains almost greater than exponential growth. What is causing that? Well, I can tell you that a study literally that just came out, hot off the press, is that one of the things which seems to be very clearly involved, and this is going to be a theme that you're going to hear over the next close to an hour, is the microbiome. Apart from genetic factors, which take a tremendous amount of time to develop, it's the gut microbiota that play a role in ASD. For example, children with ASD have a very distinctive and underdeveloped range and a volume of gut bacteria, which interestingly enough is not related to their diet. So we know that the microbiome functionalities are associated with neurotransmitter synthesis, much of which is synthesized in the gut. And by what? By the microbiome. And that's really reduced in children with ASD. So The conclusion is really that shifts in the gut microbiota during early life, and remember early life here because we're going to come back to that, in early life development can have very important functional roles in the pathogenesis of ASD. Very interesting study. If you want to look it up, we can always send you the actual article. So that brings up the whole issue of the hygiene hypothesis, which basically says, what is it that has caused the following? Since 1950, look on the right, infectious diseases going down to around 2000. In the industrialized countries, those infectious diseases have gone down dramatically, almost to nothing. It's quite a wonderful sight when you look at it. But what has happened at the same time is there's been an incredible increase in a whole series of what we now know as various autoimmune and autoimmune-like diseases in those same industrial countries. Multiple sclerosis, Crohn's, type 1 diabetes, asthma, etc. We didn't quite understand what was going on, but we're getting a much better handle right now on why that's the case. And I'll go over that in just a few minutes. But what we do know is that increasing incidence of autoimmune disease in industrialized countries, remember, we're talking about those countries, may be explained by changes in early microbial exposure, which then leads to an altered immune maturation. Remember that, because that becomes very important. And so now I'm going to put together a table and a scheme that we will be discussing over the next little while. And it says that if you're looking at the pathogenesis of chronic inflammatory disease, you need to take a certain amount of things into account. Genetic predisposition, of course. The susceptibility that one has genetically is clearly very important, but cannot be the reason why things have changed so quickly. Our genetic system does not have the capability to be able to change that quickly. What can be important here are environmental triggers, nutrition, the infections that we have, the antibiotic use, etc. Thirdly, the microbiome, especially when that microbiome, remember that means the microbiota in the gut, when they're dysbiotic, meaning they have lost their hemostatic ability, they're now unbalanced, critical. When that happens, it causes a problem in the immune response, both the innate and the adaptive immune response. We will discuss that as well in a few moments. And that becomes a to and fro. With that change in immune response, that can aggravate inflammatory issues, which then can aggravate the immune response. And number 5, extremely important, increased intestinal permeability and the loss of the barrier, the intestinal barrier integrity. When you lose that, all bets are off. And at that point, it changes the clinical outcome. And that clinical outcome can really go 3 ways. It can resolve itself, the resolution, or it can go to chronic inflammatory disease. And in fact, that can even lead to autoimmune disease issues. So we do know then that chronic inflammatory disease has as its underpinning an underlying metabolic problem. It underlies most diseases. And we know that the cause is an imbalance in the immune system. And so the goal in any kind of treatment is to bring back immunobalance. And how do you do that? Normally through what we call today immunoregeneration, being able to get the immune system to start to create a hemostatic level, which is going to be able to give you hemostasis in general. And in our modern societies, as I say, this war is not being won. And why not? Well, one of the reasons is that the management approach which we've had up until now is not sufficiently targeted. It's not targeting the right things that you need to target to get at the core issues. And the healthy aging concepts are not being followed. You're not getting enough exercise. There is an unbalanced diet. We are using industrial food production, etc. We can go on indefinitely. What's the result? An inflammatory state in its various edifications, which leads to any number of things which are now in many cases epidemic, definitely in North America. Obesity, which I'll get into in a few minutes, type 2 diabetes, inflammatory bowel disease, rheumatoid arthritis, cancer, etc. But we do know that there's a way to deal with this, and it's called autophagy or autophagy, which literally means, from the Greek, self-eating. The body is able to cleanse damaged cells in order to regenerate newer, healthier cells. And it only works if the process of that repair is more robust than the process that's damaging the cells. And so now we begin to understand that a major control of autophagy is in fact diet. And I can say diet and supplementation. In fact, you create the concept, which I know Jeffrey Bland in functional medicine has made very popular, the whole concept of diet as medicine in and of itself. You allow time for the immune system to reset. That's the whole process behind intermittent fasting, for example. You enhance the intake of phytonutrients. How? Through diet and supplementation. And at the same time, you are ridding the body of the various toxins, and we can discuss that in detail, endotoxins, parabens, etc. And so let's take a look very quickly then at increased intestinal permeability. I know you're all aware of this, but just to make sure you understand, the gastrointestinal mucosal system has a very robust immune hemostatic system. In fact, it's called the gut-associated lymphoid tissue. Here is a picture of histology of a rat in which you see the epithelial lining around the gut. And here is one of these lymphoid patches, classic Peyer's or Peyer's patches. And there you see the immune cells, the white cells, which are T cells, the blue stain, which are B cells, and the green ones, which are dendritic cells. Those are the cells that literally push pods through the intestinal system out into the lumen of the gut to check what's going on out there. And there is always an interaction of the epithelium and the immune cells. And this GALT, this gut-associated lymphoid tissue, is in fact a containment system. And together with commensal bacteria, the good bacteria, it prevents potentially harmful intestinal antigens from getting out of control, from actually getting out of the gut into the systemic circulation, which is where you don't want them. So you need this GALT system and the bacteria to induce what's called systemic tolerance. You want to make sure that the antigens are not getting into areas they should be. And the way in which that gets done is by, number one, having a wonderful layer of mucus above the apical areas of the barrier cells in the intestinal lining, and within that mucus to have a lot of Sig-A, that is the immunoglobulin A that is secreted. And the other thing that you need to remember is the paracellular or intercellular area and the tight junctions. Very well known today. There are a whole series, dozens of proteins that make up this net, this kind of closure that is there, this junction, this door that will only open at certain points. And we now know that that particular tight junction is controlled by a biomarker called zonulin, which is one of our fundamental biomarkers, which we have in our intestinal series of blood spot biomarkers. And it controls the opening of the paracellular tight junction. It's a game changer. This is the first objective biomarker for permeability change, used to call it leaky gut, and it is in fact a very important biomarker. It's a defense system which was created in the body to flush out microorganisms. If those antigens and bugs get into the other side of the epithelial layer in the gut, you need to get them out. And the way you get them out is you just bring them into solution and push them back out into the gut. And you got to open up the trapdoor to do that. What controls that? Zonulin. And so if you look at just recent look at some of the, just a short list, by the way, there are many more than this, updated around 2018, zonulin and chronic inflammatory disease, what you're realizing is that there are a series of steps that lead to the break of tolerance and subsequently to chronic inflammatory disease development. And it's similar for all of these particular disease processes. You need a genetic predisposition. You need to have certain environmental triggers. They're different for different diseases. And the barrier needs to be disrupted, which will increase intestinal permeability. And what's that going to do? It's going to dysregulate the pathway due to zonulin, and that's going to cause the problem. So over the next few moments, let's take a look at some classic diseases. The first one, which is really a predicate disease, because the work on zonulin was actually done looking at celiac disease. Celiac disease is a very interesting disease because we're beginning to understand really how it functions. And if you take a look at this graph to the right, looking from 1950 to 2020, it seems to be very close to what we saw with autism spectrum. You see an exponential increase in industrialized countries of celiac disease. And we're seeing an incidence which is increasing about 7.5% per year. That's enormous, by the way, in the last 30 years in industrialized world. And in fact, it's highest in females and in children. When you pool that with the global area, it's about 1.4%, because remember, we're not seeing these same changes in some of the non-industrialized areas. And we know that the undiagnosed prevalence of celiac, people with celiac walking around with it, but it's undiagnosed, has a dramatic increase. In many of the industrialized countries. In the US, for example, the 21st century, it's a massive increase. And we know that 83% of the people with celiac are either undiagnosed or they're misdiagnosed. So the number that we're seeing with celiac is probably quite low relative to what it really is. And if you then take into non-celiac sensitivity, which is about 10 times that of celiac, you're looking at somewhere between 20 and 30% of the population suffering from frank celiac disease or something which approximates it in terms of symptoms. And we know that the causes for the increased zonulin with celiac disease is due to microbiome imbalance. Dysbiosis is the key factor that is driving celiac disease, be it bacterial, fungal, parasitic. And in fact, gliadin, which is a part of gluten and is known to be the entity which creates the celiac disease spiral, in fact, is being looked at by those with celiac disease very much like it is a pathogenic bacterium. The body perceives it that way and reacts in a fashion which creates celiac. I'm just giving you a quick overview. We can go into much more detail on any of these diseases. In the case of diabetes, we now know that both celiac disease and type 1 diabetes patients show much higher serum zonulin levels compared to controls and even their relatives. Their relatives have higher zonulin than the controls, but people with frank celiac and type 1 diabetes are much higher. And so we know that diabetes is in fact related as an initial pathogenic entity, the microbiome and gut permeability. What about inflammatory bowel disease, Crohn's, ulcerative colitis, etc.? Well, we do know that increased intestinal permeability is central to the pathogenesis of IBD. That's been known for quite a while. And we know that that is due to an innate immune deficiency. Now, what does that mean? An innate deficiency is due to three components, really. It's the physical barrier, those tight junctions, together with the various antimicrobial peptides produced by the cells and Some of the bacteria themselves are called defensins, and they are sitting in the mucoid layers of the gut. We also know that there are cytokines and various types of inflammatory mediators which are produced by some of the classic portions of the immune system, the mast cells and the macrophages, which sit inside those Peyer's patches in the area of the gut and are produced in vast amounts within the gut area, much, much greater than they are in the rest of the body. In fact, mast cells and macrophages are produced about 80% in the area of the gut. And all of that leads to an inappropriate access of both food antigens and bacteria into areas that shouldn't be, and that stimulates GALT. And so we know that if you were to look at an asymptomatic Crohn's disease patient, someone who isn't exhibiting exacerbation of Crohn's, we know now that intestinal permeability in those patients precedes a relapse by up to 1 year, which makes it quite clear that it is a defect in intestinal permeability as one of the early events in the exacerbation of the disease like Crohn's. And it's due to the cytokines like IFN, TNF alpha, that's necrosing factor. They're part of what's called the adaptive immunity response, which is one that causes what we call today immune dysregulation. And that manifests itself in all kinds of organ systems depending on the susceptibility of the individual. There are a number of other issues. If you take a look at multiple sclerosis, and as I said, I'm just giving you a quick overview. There are many of them. You see serum zonulin elevated in upwards of about 30% of patients with relapsing, remitting, and secondary progressive multiple sclerosis, both of the major types of MS. And we do know that there's a twofold increase in patients who are going through an exacerbation of their MS. And interestingly enough, the zonulin levels decrease in these people down to controls when they are in remission. So that's a clear idea that serum zonulin is part of the issue with multiple sclerosis. But what about some other diseases? Let me look at one in particular, which I think is quite fascinating and has become a worldwide epidemic. Here is something from WHO of 2017, and it shows you the obesity rates in the last 40 years in a number of industrialized nations. It's clear what's going on. Obesity rates are going up dramatically. In fact, in the United States, it's not a hidden epidemic. It's a very clear epidemic. Walk down any street anywhere in the States and you see the signs. Go to 2020, 74% of adult Americans, including now children over the age of 6, I believe, are in the obese area in terms of their BMI, etc. And what do you see? You see the increase, significant increase in zonulin levels in these people. In fact, there are a whole number of studies now, very recent, which look at zonulin and its relation to morbid and childhood obesity, the inevitable fatty liver disease, etc. It's clear. So, what does the microbiome have to do with all of that? Well, what is the microbiome? Well, it's what goes on in the human gut. The microbiome has somewhere in the area of around 150 trillion cells. Cells of bacteria outnumber those of humans 10 to 1. If you take a look at all the genes that are expressed in all of those cells, the genetic information in all of those bacteria outnumber humans 150 to 1. And in fact, there are well over 3 million bacterial genes versus a paltry 25,000 human genes, which the Genome Project told us, about 20 years ago. That's extremely small relative to even many other animal species. Within the gut, we don't even know, but we think there are over 10,000 species of bacteria, of which, by the way, we have a passing knowledge of perhaps 2, 3, or 4%. And I think I'm being generous. So we don't even know what all those bacteria are doing. And we can discuss that in terms of some of the companies coming out with biome testing, etc., and some of the problems that you have in doing that in and of itself. 50%, fully 50% of colonic content in stool is bacterial. And so there are some facts that you need to know. By weight, we carry about 2 or 3 kilograms of bacteria. The volume, about 1.5 liters. Species, as I said, over 10,000, we don't begin to know. Does it produce gas? Yes, about 1 to 4 liters a day. What about waste? As I said, 50, even 60% of the waste product in stool is bacteria. We do know that it develops very early in life. It's established by the age of 3, and it expands the genetic and the functional capacity of the human host. Remember, human host has 25,000 genes. Add a few million of the bacteria, now you have something that is potentially huge in the way that it can respond to outside influences. We know that children, the founding gut microbial population, will shape their immune function. And because of that, the disease outcomes. So there's a very, very strong association of early childhood microbial colonization and health status for the rest of its life. That's very, very important. And we do know that antibiotics can have a dramatic and very rapid alteration of the microbiome, and that can last for months. 50% of females, we know, receive antibiotics during pregnancy. There are fewer antibiotics given to men, etc. We know that most children, by the age of 3, have had somewhere between 7 and 10 courses of antibiotics. And it's one of the reasons that the Association of Pediatrics in many countries is telling their membership, please stop using antibiotics unless you absolutely need it. And so we also know that antibiotic use is paralleling obesity in the United States. And that's one of the things that is involved in increased weight gain, especially in children. So we also know that reduced bacterial diversity is a very important element in dysbiosis. In fact, it is a major effector in many diseases. In other words, you increase the diversity of all the bacteria in there, and you're going to be much more prone to any of these things you see on the left, from diabetes to obesity, etc. And we know that there is a very strong correlation of dysbiosis and human disease. We know locally, IBD, IBS, necrotizing enterocolitis, which is what you see in children. These are all localized issues. They're very bad, but they're very localized. But it can become systemic due to the metabolites, inflammatory cytokines, the signalers, and the various PAMPs. These are pathogen-associated molecular pattern molecules produced by various types of bacteria and antigens. And you see just below all the different diseases involved in what happens with dysbiosis. And it's due to, as I said, the metabolites, the secondary bile acids, etc., the various types of inflammatory cytokines, TNF-alpha, etc. And I mentioned diversity. If you take a look at animals living in the wild, they have very diverse bacterial colonies when you look at one animal to the other. You bring them into captivity, and that diversity begins to go down significantly. Then what you do is you take a look at non-Western human society, and you see that the diversity is getting even worse than it is in captive animals. But that's not the end of it, because if you look at industrialized society, what you notice is that our diversity has gone down to almost nil. It's extremely low. And by the way, for those who are interested in this, Dr. Knight and his team that are involved in this whole bacterial microbiome world. It is a phenomenal project. If you look at his TED Talk in 2017, just wait to be inspired. It is a wonderful talk. And so let's just take a quick look at some of the factors that are affecting gut microflora. And one of the things we can look at is birth mode and the maternal flora, etc. And what we do know, and it's now very well understood, is that there is an extremely important effect of how the child is born. There's a birth delivery baby biome study, which is ongoing, by the way, and it looks at fecal samples of newborn babies. It looks at their meconium, which is the stool coming out after 24 hours. And it looks at babies that are born vaginally or by cesarean. And if you look at those that are born vaginally, the microbiome does not look like the vaginal bacteria, but in fact, it resembles the mother's gut bacteria. In fact, there are very few of the mother's vaginal bacteria in there. Originally, they thought it was vaginal. It's not. It's representing what the mother's gut bacteria was providing to the child as an embryo to the moment of birth. On the other hand, if they're born by cesarean, most of the bacteria are from, in fact, the hospital environment in the gut, from the skin, from the nurses, you name it. Definitely not from the mother's gut. And you should note that most women to date have been given antibiotics just before they get a C-section to prevent post-op infections. So what we're thinking is that the baby, just as it's coming out, is already receiving a antibiotic dose, its first of many in the first 3 years, this time via the placenta. And we are now pretty sure that that may be causing some of the initial microbiome differences. Secondly, what's the role of breast milk? Well, we do know that food, other environmental antigens come in through the mother and eventually get in through the gut barrier of the baby. And there are a whole number of things in breast milk that you see here in yellow, but I want you to take a look at the last one, which is human milk oligosaccharides, HMOs. Well, what are they doing there when in fact we know that the baby can't use the HMOs? The HMOs are there as a prebiotic for the commensal intestinal bacteria. Those bacteria need the HMOs. The baby, in fact, cannot break down those oligosaccharides. So the breast milk recognizes the importance, the critical importance of the bacteria, and is a prebiotic for those bacteria to be able to prosper even in the child when it's born. And it's critical for gut health. And so it leads you to an understanding, which I'm not going to go through here in detail, that everything from prenatal factors, the maternal nutrition, right through the first 3 to 5 years from birth, malnutrition, the amount of antibiotic use, of course, the infections, inflammation, you name it, will have a dramatic effect on adult health risk factors, obesity, metabolic syndrome, cardiovascular disease, type 2 diabetes. Just yesterday, there was another article about how that affects asthma, and the list goes on and on. And in fact, in aging, we do know that the microbiome changes. And by the age of 40, there are distinct changes in the microbiome. And for those lucky individuals where they begin to get a highly divergence that starts in the microbiome after the age of 40, they become much more resilient. And we realize in these people that they show in the microbiome and in their gut much higher levels of metabolites, which are produced by gut microbes, including indoles. And for those of you who know about indoles, we know that they reduce inflammation and can help maintain barrier integrity. We also know that there is a very steep decline in these lucky individuals in Bacteroides species, because we know if it doesn't decline, if it remains at a higher level, it can attack the thinner mucus layer that you see in the gut lumen as people age. And that will trigger stronger immune response, which of course is part of chronic inflammation. And this is where you get the importance of diet and supplements. You need that, especially as one ages, to preserve that mucus layer in the gut while you're aging, and by increasing the amount of fiber. And we're going to go into that in just a moment. You need to increase the indole production. Why? To maintain barrier protection. So therefore, we can take a look at this and see, and there are nice little colors here with all kinds of different diseases, but gut microbiota are now implicated in all of these diseases and more. And we know that an increased gut permeability can lead to obesity due to dysbiosis. And we know from a whole number of studies that obesity is associated with a phylum level change in the microbiota. So there's reduced bacterial diversity, and you see that in the difference between those who are lean and those that are obese. If you have less diversity, much greater chance of being obese. So you need to increase the diversity. And there are just an incredible amount of studies that show that there's an increase in intestinal permeability, and that is what's associated with gut inflammation, and it will precipitate the development of a whole number of things, including the great ones here: obesity, fatty liver, which is, by the way, typical of obese subjects, and of course, type 2 diabetes. So if you then look at microbiome and immune modulation, I should tell you, if you want to look at this when you get to PDF, all of these things are involved with microbiome, including the regulation of Treg cells. Those are regulatory cells, but we're going to concentrate on metabolism and how it plays a role in fermentation and in production of short-chain fatty acids, etc. Let's take a look at some of the probiotics and what else it's able to do. We know that antibiotics, as I said earlier, is a major problem. 80% of what is sold in the United States is sold, interestingly enough, for animal production. And the reasons for that, of course, we know is to decrease gastrointestinal infection in cows, and it also increases their weight. And even today, 50% of beef and poultry are still given antibiotics. And so we know from the figures of 2013, they've probably gone up. About 30 million pounds of meat and poultry is given antibiotics, 30 million pounds of it. And that gets into the manure, increases plant antibiotic concentration, which of course means it gets into food content. On top of that, close to 8 million pounds of antibiotics are given to treat human disease. And so that ends up with the situation we have today, which is a very strong increase in risk of allergies and food sensitivities. Most of that due to antibiotic use in the first 2 to 3 years of life. Please remember that, because of all these 7 to 10 regimes of antibiotics given in the first 2 to 3 years. And of course, what that does is it programs the body for the remainder of its life, especially the immune system. And we do know that if you take a look at a series of antibiotics, in this case, Bacteroides, we know that the humans only have about 20 genes that are encoded to break down carbs as they move through the gut. Bacteroides alone has 260 genes, and there are another 1,000 or so bacterial species that we know are involved in the breakdown. So microbiota don't just help the digestive function, they are essential to digestive function. And I'm giving you just one example of Bacteroides theta. I'm not going to give you the full name because I can't say it. If you take a look at the complex plant food carbohydrates, various types of polysaccharides, then they're digested by Bacteroides theta. It has those 260 enzymes, and that's what in fact breaks down all of these polysaccharides into short-chain fatty acids in the colon, and that's what we're able to ingest. And so if you take a look at nutrition, we do know that food sensitivities and inflammation are intimately connected. They are triggered by food antigens, lectins, of course, chronic stress, which we're not going to go through today. We're going to do that in later lectures, various chemicals, and the dysregulation of the immune system, the IgG, mNA, that leads to cell activation. Which ones? The various lymphocytes, the monocytes, and of course the baso and eosinophils. And with them, you get release of mediators, the classic cytokines, histamine, which is another one of the things we test for in our blood tests, and prostaglandins. What does all that do? It creates the pathologic effects that we see. Tissue damage of various kinds, pain receptor activation in many organs, especially the gut, smooth muscle contraction, edema, swelling, neurological and endocrine dysfunction, and last but not least, increased gut permeability. And so we really know only about 17% of the possible causes of food sensitivity, and they're mentioned here. What we don't know is the cause of fully 83%. We do think the most important reason is dysbiosis, and it's the change in the percentage of commensals to pathogenic bacteria. In fact, the rule of thumb is if you go down to less than 85% commensals, the problems begin. How it begins, we don't even begin to understand in any real way. We do know the second thing is chronic stress, which I am not going to stress today. But if you take a look at some of the things we do understand, we do know about the Mediterranean diet, and all of you are familiar with that. We do know that about 2.5 million years ago, the human race appears. You begin to see the diet of fruits, of tubers, nuts, meat, and everything continues very nicely up until about 10,000 years ago, when we're beginning to change from nomadic to farming life, agriculture begins, and gluten grains are developed. And that's when things begin to go sideways. So you begin to look at a number of things, the diet and the microbiome. First of all, the diversity of the human microbiome. We have much less diversity than other primates. I showed you that earlier. And that's driving many of the modern diseases. Autoimmune, like asthma and metabolic diseases, etc. The lowest diversity is in Western postmodern societies. But why is it low in all humans? Because it is lower. And I just mentioned some of them. We've gone from nomadic to sedentary agricultural life. Gluten has become much more prevalent, and I want someone to ask me the question later, why is it more of a problem in North America than Europe? We cook our foods and therefore decrease the need to break down the bacteria of plant food, especially fibers. We have much less fiber in fermented foods, and the antibiotic use that I mentioned. And so the question that one asks is, so what's an optimal bacterial community? Well, we know that humans were hunter-gatherers for 300,000 years or more, even before they became Homo sapiens. And now there's been this recent rapid change in diet and lifestyle. The microbes are very highly adaptable. They can change their activity in days to weeks. The human genome is not. It takes thousands of years. But if you bring together the human and the bacterial genome and consider it as one basket, now you begin to see why the human system, which also has the bacterial genetic information, can change relatively quickly. So we now know that there's a suboptimal gut community in modern societies. Even healthy people harbor suboptimal deteriorated microbial populations. And so it's pushing us towards all those new diseases that I showed you in the beginning, which are part of this hygiene hypothesis. So how do you improve it? Well, first of all, increase food and dietary fiber, the prebiotics. So you're feeding the commensals. That's what you really want to do. Supplements, the probiotics, they will give you a transient improvement. Let's not get too far afield here. If you give just supplements, the effect of that is gone 24 to 48 hours after you stop the supplements. However, if you give the supplements with fermented food and the dietary fiber, you will maintain to a much greater degree the probiotic effect that you're looking for. And I'm just going to throw in, you better get rid of the inflammatory state of the gut before you do that. And if somebody wants to ask me that question later, go right ahead. Remember, the microbiome is effective in colonization resistance. In other words, when something comes in, it normally will try to resist a change unless it feels that the foreign entity is able to make things better. Otherwise, it will not allow it to work. And I do want to bring in one other thing, and that is sleep. It has not been discussed enough. Sleep and the microbiome. It is key to the understanding of what we call restriction diets. If you remember, restriction diets are based on an 8-hour window of eating in its various forms, and then you have a 16-hour of restriction. But what does that do? Well, one of the things it does, one of the key issues, is that it allows the sleep cycle to promote certain things. The GI tract is able to initiate what's called an emptying wave, which we know occurs every 90 minutes. Every 90 minutes when you're sleeping, you move out undigested food distally. It moves down into the colon. There's fluid secretion, a wave that moves food distally. And the microbes that migrated from the colon back into the small intestine are pushed back into the colon where they're supposed to be. So you decrease SIBO. If you're not sleeping enough, if you don't have high enough levels of melatonin, which have a very strong gut relationship. They're produced by bacteria that produce tryptophan, and they're a very strong antioxidant. You are going to create microbial stress because there's insufficient time to cleanse the gut. Please keep that in mind. And so the last thing I'm going to discuss the last few minutes is gut microbiota targeted diets. Remember I mentioned high fiber plant-based diet. It will increase some microbiome function. It's going to create various types of personalized immune response, but it is not as effective as high fermented food diets, which will produce, number one, very high diversity, extremely important, and it's going to decrease the inflammatory markers. So what that tells you is that fermented foods, as is mentioned by Wastik in this 2021, it's literally hot off the press, may be powerful modulators of the human microbiome immune system axis. And as he says, provides an avenue to combat non-communicable chronic diseases. And lastly, I just want to mention the dietary patterns that induce poor microbiome balance, inflammation, chronic diseases, and they're all linked to increased intestinal permeability. And the three important nutrients which you can get that are going to help are glutamine, the flavonoid phytonutrients, and probiotic supplementation. In the case of glutamine, it's extremely well known, but just to make sure we all agree, it promotes enterocyte proliferation, so the gut is able to rebalance itself. Those cells are able to regenerate and regulate the tight junctions. It is going to suppress pro-inflammatory signaling, and it protects the cells from apoptotic and oxidative stress and cell death. So it's an extremely important thing to have. And by the way, you get that through supplementation and diet. And with that, it's going to modulate the tight junctions and promote the SIG-A, which is immunoglobulin A secretion in the mucus of the lumen. Extremely important. Flavonoid phytonutrients, We all know about that. You can get it through diet, but very often requires supplementation as a very potent way of creating immediate anti-inflammatory agents, which can then be aided by the fermented and fiber diet. And berberine, which is one of them, there are a whole number of studies, by the way, which look at berberine. And for those who are interested, I've shown you this particular study, again, which is quite recent. One of the things you need to know as well is probiotic supplementation and the microbiome is critical, because you try to balance the microbiome, and that will benefit immune function, and it's going to improve the gut barrier. Critical. And if you look at this slide in detail, spend some time to look at it, because it's going to tell you what's going on. As a therapeutic summary, these are things that I'm sure you know well, but I think it's important to have it on a list. These are key supplements, from omega-3s to glutamine. Of course, vitamin D, that's a very controversial vitamin. Is it 1,000 IUs? Is it 5,000? Is it 10,000? I don't want to get into that argument, but definitely you need it. Both the probiotic and the prebiotics, especially if you've decreased inflammation in the gut, the various types of minerals, and the flavonoids, including berberine. And I wanted to mention as a summary this, the importance of the first 2 to 3 years in driving chronic inflammatory disease and autoimmune epidemic. And this is an important slide. If you have vaginal delivery, you get proper nutrition, there are low infections, and so low amounts of antibiotics, the microbiome composition is balanced. If, however, you have things like C-section, improper nutrition, multiple infections requiring multiple antibiotic treatment, remember, in the first 2 to 3 years, that's going to create almost inevitably dysbiotic behavior. Now, if it's a balanced microbiome, that's going to allow the immune system to have a high threshold. It doesn't get kicked into action very quickly. That's what you want. And if you add to that a very good genetic predisposition, you're going to have a normal response to antigens and a good state of health. But if you're dysbiotic, therefore creating an inappropriate or very low threshold for that lymphoid tissue, and with that, a genetic predisposition, you're going to get pro-inflammatory responses to antigens, which in effect leads to chronic disease and epidemics. But if you use probiotics, prebiotics, or what we call symbiotics, which is doing the two together, that is going to promote a balanced microbiome, and it will not allow dysbiosis. And so today, when you're analyzing, you need to look at what we call omic or multi-omic analysis. You're looking at the microbiome, the metabolome, the proteome. By the way, 10 years ago, we didn't even know what these words were. The genome, the epigenome, the transcriptome, and the nutrigenome. What's feeding all of this? And from that data integration, you can develop what's called a multi-omic portrait, which leads you to what today is being called an exposome. That's looking at the totality of all of the external exposures that can lead to both problems at an organ level and at a cell level. And so I do want you to know that Fluids IQ has a manual called the Intestinal IQ Supporting Gastrointestinal Health. And in chapter 3, we spend chapters going through all the different biomarkers. But in chapter 3, it actually tells you how your colleagues normally stage treatment and what you need to do, the staging, the step-by-step that you need to do, so that you don't end up doing number 7 before you do number 2, because it's not going to work. For example, number 6, probiotics. If you do it before you balance enzymes, give intestinal protection, create decreases in inflammation, the probiotics are not going to work to their best effect. And if you look at the back of that manual, we give you a list of all of the different supplements that are out there from various companies. House, and it's not summer in Montreal, that's it in January. Thank you very much